Shamir Mehta, Mike Gibson, we're talking about complete revascularization. Shamir, you just did an amazing meta-analysis looking at 6 different trials with some very, very important conclusions. Share with us what you found.
Yeah, Mike, we did a individual patient data meta-analysis of the six large multi-center trials of complete revascularization. And in total, we had 8,836 patients. So a large number. We had 910 cardiovascular deaths or MIs, and we had 678 deaths. So we had much larger numbers of outcome events than any single trial to be able to assess important outcomes.
And what did you find?
Yeah, so we found that, as expected, there was a large reduction in cardiovascular death or MI. The hazard ratio was 0.74, and the confidence interval is very, very tight, and many zeros on the p-value. Less than this was simultaneously published in the Lancet. They allow 3 zeros on the p-value, so it was less than 0.0001 for CV death or new MI. That was also shown in the complete trial and a couple of other trials. But the really big information or new information from this is that there was also a robust reduction in cardiovascular mortality alone. Here we saw a 24% reduction in cardiovascular mortality, again with 2 zeros on the p-value. So a really solid result in terms of that reduction. And all-cause death as well was reduced by about 15% in the trial. So not the trial, in the meta-analysis. And it's interesting that all of the reduction in mortality was due to cardiovascular mortality. There was no difference in non-CV deaths. The curves for non-CV deaths are superimposable with each other, but they diverge quite significantly for cardiovascular death. So I guess that's the new finding, that complete revasc is a class 1A recommendation already on both sides of the guidelines. I will say there were skeptics out there. The trials by design are open label trials. The benefit was on non-fatal outcomes. And there were people asking questions about, does it reduce mortality? Well, yes, the answer is yes, it does reduce mortality. We just needed to have enough patients to be able to show that. And now we do with this particular analysis.
So 24% reduction in mortality, that's the relative reduction. What kind of absolute reduction were we talking about there, Shamir?
Yeah, so the event rates were reduced in terms of cardiovascular mortality from 4.6% down to 3.6%. So a 1% absolute reduction in cardiovascular mortality.
Wow. So you only have to do 100 primary PCIs in this fashion to save one life.
You got it. 99 actually, to be precise. So 99 primary PCIs to save one life, and 41 primary PCIs to save one new MI or cardiovascular death.
Wow. And which lesion should we intervene upon in the non-culprit artery? I mean, are we talking about a 50% diameter stenosis, a 70% area stenosis, 70% diameter stenosis, a flow-limiting lesion, non-flow limiting? How do you decide?
So we looked at a sub-analysis where we looked at complete revascularization according to an angiographic guided strategy where only lesions that were tight over 70% were opened, or a physiology guided strategy where physiology dictated which lesions would be open. And we found a benefit of both strategies with absolutely no interaction. As you know, we have the large complete 2 trial ongoing right now, 5,100 patients. We're almost finished enrollment in that trial, which is a head-to-head comparison of physiology and angiography guided strategies, hard outcomes, OCT imaging, and 1,500 of those patients. And we'll have the answer to your question. In the meantime, we'll have some sub-analyses, which will bring us a little bit closer to that, but I don't want to steal the thunder from some of my co-authors that will be leading those papers.
I just looked at 2,500 primary angioplasty films in the past couple of years doing a trial. And I gotta say, this is consistent with 30 years of experience in doing this. I look at it and sometimes I say, ooh, boy, I don't know that that was the primary lesion. You know, there's this tendency to dilate the tightest lesion, but you look over there at the non-culprit and it's much more complex. It has clot and thrombus. And so, do you have any sense how often the non-culprit was really the culprit?
We don't, but we suspect that in the STEMI situation of STEMI, we can identify the culprit fairly easily because we have the ECG, the ST elevation, and then the total thrombotic occlusion often or subtotal occlusion. In non-STEMI, it gets, as you said, it's a little bit more dicey. Sometimes we're not exactly sure, and we need intracoronary imaging or we need other modalities to help figure that out. But it's interesting when we looked at the STEMI versus non-STEMI hazard ratios, there was absolutely no interaction between the two. Um, Having said that, of the 8,800 patients, only about 1,200 were non-STEMI. So we need more data. Holger Thiel is running a big trial in the non-STEMI population, so it'll be interesting to see the results of that. But for now, the results were completely, consistent in the two groups.
Well, congratulations. Very important study. I think it does change practice or give us reassurance that what we're doing is the correct thing to do. Does not apply to shock patients, right?
Shock patients were excluded.
Yep. Well, great work as always, Shamir. Thanks for joining us today, and thanks to all of you for joining us here from AHA 2025.